Hi, Cindy. We can go ahead and start. Hi, welcome. We'll get started here in a minute. Great. Hi, welcome. Great to see everyone coming in. Good morning. My name is Lindsay, and on behalf of the Office of Oral Health, I would like to welcome everyone to our June 6th virtual project directors meeting, Oral Health Models for Success, Medical Dental Integration, Fluoride Varnish Pregnancy, and School-Linked Dental Programs. And Cindy, can you share the screen, please? Well, our objectives for today is for local oral health programs to learn best practices to expand and maintain sustainability of school dental programs, how other states have advanced school dental programs, and strategies for medical dental integration. We'll be trying something different today with our chat. We have a Q&A feature added to our PDM for today. And so this will help us track the questions and answers better, especially for any follow-up that we have. So if you can see at the bottom of your screen, there should be a Q&A and a chat feature for questions. Again, just please drop them in the Q&A part of the meeting. You can also use the raise hand feature if you have questions during the question and answer sessions that we have. So oh, thanks. Okay, so here's our our overarching slide, and then we can move to the next slide. There's the official title for our PDM today, and then next slide. Great. Okay. So I would like to welcome each of you as local oral health program leaders and staff. We invite you to include your organization in your Zoom name. That helps our staff know who is who, especially any new staff. And if you're new, it's helpful to know which county or local oral health program that you're with. And then we encourage dialogue throughout the meeting, especially if you have questions for other LOHPs about how they're doing this work. So don't be shy. And then we also have included the agenda and speaker bios with the registration. And they're also available at the event website. So we'll drop that in the chat so you have those resources. Speaker slides and the meeting recording will be made available after the session on the COTAC website. And we'll send out an evaluation after the meeting. So our goal today is to have an overview of successful models and ideas on how to implement those models at the local level. For the first part of our meeting, we will look at successful models for integrating medical dental efforts. This includes pregnancy, fluoride varnish, and chronic disease. We'll get to hear an LOHP success story of how they're doing this work. And then we'll have a break. And after the break, we get to hear about 2 school-based, school-linked models, as well as another LOHP success story. So we're really excited for our layout for today. And then if you could share the slides one more time, we have I'd like to introduce Paula Lee. She is the, so next slide. All right, great. She is the policy lead and school dental program coordinator with the Office of Oral Health with the California Department of Public Health. and she is also a mindfulness leader. And so we'd like to welcome her to lead us in a mindfulness minute. Thank you, Paula.
Good morning, everyone. Here at California Department of Public Health in Tomas, Aragon, he leads our department in Mindful Moments, and I have also brought that from when I came here to the Office of Oral Health and Mindful Moments. So it is just really a time to tune in to our bodies and our minds and tune out the external environment, and just to have a moment to just center ourselves. So I invite you all to get into a comfortable seat. And you could put your both feet grounded on the floor, kind of uncross them. You could have your palms facing down or facing up. Down is kind of a grounding, and a palm facing up is kind of like a receiving posture. I do invite you to close your eyes if that feels comfortable to you. And if not, you could just have a nice soft gaze down. And we'll go ahead and take a community breath together with a nice inhale. So go ahead and close your eyes. And we're just going to start with a breath. So go ahead and do a full exhale with the air in your mouth. A nice deep inhale through the nose. A nice exhale. Release. Then do another inhale. A nice exhale. As you take a moment to settle into your body and into your mind for the next minute, as you relax and release, start with noticing any tensions in your body. And on your next exhale, just go ahead and release that. Release your jaw, create some space. Release your shoulders. Your next exhale. Release your chest, your abdomen, and your back. Release your arms and your legs, your wrists and your hands. Take time to release your ankles and your feet. Now take a focus on your thoughts in your mind. As thoughts come, just observe without judgment or a push and pull needing to fix anything. Just observe your thoughts as if you're on a train watching the scenery go by out the window. Know that collectively together, that you yourself are exactly where you need to be, that you belong in this space, and together we make the fabric of public health in California. Can repeat a mantra, I belong. Let's say that one more time. I belong. And together, let's take 2 cleansing breaths together. Nice big inhale. Nice complete exhale. One more together. Nice big inhale. And nice complete exhale. If you had your eyes closed, I invite you to open them. And next, I will pass it on to Dr. Lynn Walton-Haynes. She is our dental program consultant here at the Office of Oral Health, and she will give us an overview of our office's medical dental integration. Dr. Walton-Haynes.
Thanks, Paula. Can you all believe that we get to experience that to start our week off every week? So that was wonderful, as always. Good morning, everybody. Try to wake us back up. That was very relaxing. So we can go to the next slide. Nope, we can't. Actually, I would like to start off actually by letting my colleague, Cara Vieira, give a few updates on the budget. First, I do want to let everyone know, because it's probably on everyone's mind, do we have a new state dental director yet? Not quite, but we're very hopeful that the process is going through, and we hoped, you know, hopefully in the near future to be able to let you know that that we do. So the other thing that's probably on people's mind is the budget. So Cara Vieira is my colleague from our business operations section in the Office of Oral Health. Cara.
Good morning. Thank you, Dr. Walton Haynes. Thank you for letting me take this time to update everybody on our budget, because I know it's something that's on the forefront of everyone's minds. Once again, like Dr. Walton Haynes said, my name is Cara Vieira. I'm a grant manager here in the Office of Oral Health. And I know personally I've received a few questions about the state of the budget, because the May revise came out, and we just want to clarify everything for you, because uncertainty does not settle well, at least for me. And on behalf of my manager, Kimberly Steele, who's unable to attend today, we just want to let you know that we do understand that the budget for the next 2 years is looking a little grim. Our program personally saw a significant change in our funding from the governor's January 10th budget to the May revise, and we're still kind of working through and considering all the implications. But the good news is we do not expect any cuts to our local oral health programs' annual budgets. So, whew, thank goodness. This going fall, we will permit carryover of unspent funds from current year to fiscal year 24-25. However, if the budget shortfall is ongoing, which they have kind of predicted that, we will not be able to allow that moving forward. So it'll be important to plan accordingly in your future years and the budgets. And over the last several years, Office for Oral Health, we have expanded our activities to support you all out there in the local oral health programs, which are expected to continue, so don't worry. Our current initiatives include the development and support of an electronic dental referral management system, activities focusing on data and analysis for dissemination, continuing support from COTAC, very important, and Children Now, our community water fluoridation, and maintaining and improving the system for California oral health reporting for kindergarten oral health assessments. And then lastly, despite any challenges, our team's working really hard, and I can attest to that. I see the work that Kimberly Steele and then my coworker Vinay Shukla have been doing with the budget and figuring that out. And we are all working very hard to preserve the progress that you all have made, and we're excited about the work that continues with you all. So if you have any questions, feel free to enter them in the Q&A, or probably the easiest and fastest way to get your specific question answered is to reach out to your assigned grant manager, and we can answer those definitively. So thank you. Pass it back to Dr. Walton Haynes.
Hi, and I know we need to stay on track, and I know there are hands, and I believe that we will handle those that way. And so what I want to say after that, that's kind of hard to follow. Can we have the next slide? But I think this is important, especially that we're doing this today, and that is that both of the topics on our agenda today are grounded in, our move to forward health equity, and not just by checking boxes, but really doing the work that's going to pay dividends to our communities. And so, given everything in California, we know it's not just dental that's being hit. We know it's not just health. We know that many sectors are impacted by the state's current budget situation. And so all the more reason for us to not work siloed, to not duplicate efforts, and to work with across disciplines with our partners. And so, as you know, from the summit last year, we prioritized, all of us together, prioritized medical dental integration and school-based programs as areas that we wanted to work in. And so this is just a reminder, you're going to hear about 2 of these today, but in terms of the update from the Department of Public Health and Office of Oral Health, we've been working statewide with our partners in diabetes and hypertension to really start looking at some of the older age groups as well. So I have these slides so that you'll have them later in your deck, but we can go to the next one. So this is something you've all seen before, and I just wanted to share it with you today that, we want to work collaboratively and bidirectionally. Sometimes it's the dental office pushing and information towards the medical side. Sometimes it's the other way, and we're both working on our communities collectively. When we think about fluoride varnish, which you're going to hear about, we know that for children through the Medi-Cal managed care system, that based on the preventive services report that the Department of Health Care Services puts out, that really about 20% of kids who are eligible to have like fluoride varnish, for example, are getting fluoride varnish, 20%. And that's even less in certain subgroups, down to like 12%. So, and that's eligible for this. And so use of preventive services, we have a long way to go in really seeing that number improve significantly. And so that's why the talks today are going to be so important. Similarly, there's a new measure in the preventive services, oral evaluation, and for kids under 1 year old, less than 2% were seen for an oral evaluation, and for 1 to 2 year olds, less than 20%. So we know we need to work with our colleagues in other areas. Next slide. So, as you know, you've seen this. If you've heard me, you've seen this slide. So dental professionals in community settings, like our school-based, meeting people where they are. Non-dental providers providing preventative oral health care and primary care services, which you're going to hear about. And then in that space related to schools, related to both, is integrating oral health within WIC and early Head Starts. And I know a lot of you are doing that. Next slide. Okay, this is just more to show what we're doing in the diabetes area there and hypertension screening. There are so many efforts that we're poised to be able to start looking at and seeing what we can do in this space with work that's already been done. How do we incorporate oral health into these programs that already exist? And now, the last 2 slides really are just about some efforts we've been working in that One of them, if you can go 2 slides forward. Great. So this was one that we recently worked on with La Clinica, and at the time, Dr. Anastasia Cotino was part of this group, and I just really enjoyed meeting her, found her to be just a champion and the passion for just working with people to improve their health and their situation. Just very dedicated, full-time family, physician, at the same time as working with this learning collaborative. I don't know where she found the energy. And so now what I'd like to do is to introduce her to you formally. And so just giving her time to come on. And what we want to let you know is that she is now, we're so happy about this, she's now with the Department of Healthcare Services. And is in the Division of Quality and Population Health Management. She's a medical consultant, and she's working to improve the plans to really serve youth, children, infants, and reproductive health in pregnant persons. So here I give you Dr. Anastasia Coutinho, family physician, medical consultant with the Quality and Population Health Management Division and Department of Healthcare Services. Please, Dr. Coutinho.
Thank you. Very kind words, and excited to be here with you all today.
We're getting a bit of an echo, so I don't know if you have two volume two sources on.
Don't. Oh, no.
And in the meantime, we can take my slides down and then slides to put up. Thank you.
And
I can also call in if there's still an echo.
yeah, that sounds good.
It actually shows you have another, it shows two. There's your picture, and then there's one that doesn't have a picture that is not muted. So maybe it's that one.
Yeah, I'm wondering if the other computer still was on.
Oh, that one's not connected to audio, which is why I'm on.
Okay.
But let me call him. Sorry, guys.
Yeah, and I don't, well.
Welcome to Zoom.
Okay, we'll hold for a minute. Were there any questions for, well, if we can take a question too for Dr. Walton Haynes or Kara while we're launching that.
Yeah, I had a question since we have some time. Just more about the carryover question. I'm happy to hear it's going to be coming over, and I certainly don't want to speak for other LOHPs, but I know we rely on that carryover in order to keep staff because our costs increase and the funding remains stable. So if that's in jeopardy, if there's something we can do to elucidate that, I know sometimes there's just the lack of knowledge from the state level at what happens at the local level, just by virtue of not being boots on the ground or not being, just like we don't have as much understanding of what you all go through at the state. And so if there's a way we can elucidate that and make sure that's clear to folks, I would really appreciate that opportunity because it is incredibly critical for us to keep staff in order to do the things that are outlined in our grant.
Okay, thank you. Thank you for letting us know about that. I think the best thing we can do right now is to, if you can summarize that and pass that on to your grant manager and make sure you include your program consultant in that, and they can pass that on to my manager, Kimberly. It's just something, we're not saying it's a definite, after this year it's going to be cut off. We just aren't certain, and we want to ensure that we can keep our local oral health programs going. And I totally get why that's needed on your side. So I will definitely make sure that any concerns, any background information and communication that you give us also helps us get an understanding into your processes, so we can pass that on to management, and management can pass that on to other powers that be, whether it be a Department of Finances, or Department of Finance or other areas. We can pass that on and discuss it too. But I hear you. I completely understand it. So, and then also just to kind of keep something in mind too, with, I don't know how many of us have been through a number of these, budget deficits and furloughs and serious budget cuts. It's an ebb and flow. We eventually do come out of this, start on the upswing again. So it's not a forever. Just we try to think good, positive thoughts.
Thank you, Kara. And I know, and we can come back to this topic, but because I know there's some interest. But good news, Dr. Coutinho is back on, so I'm going to pass it back to her.
Excellent.
Okay, still muted. I forget what you do on a phone to unmute.
Can you hear me now?
Yes, we can hear you.
Yes, perfect. Okay. Thank you guys. And if you can pull up my slides whenever you're ready. Like Dr. Walton Haynes mentioned, I am currently working for the Department of Healthcare Services, but we're going to talk about some work that I had done in a medical dental integration grant in my previous job, which was at La Clínica de la Raza, which is a federally qualified health center in the East Bay outside of San Francisco, California. And in that job, I served as a lead physician and spent a lot of time organizing different kind of projects, and this was one of those. My kind of niche within family medicine is treating prenatal care and pediatric care, and have a lot of patients who fall into those categories. And so just of note in the kind of project that we'll talk about, our clinical sites and many of our clinical sites already have dental and medical co-location, although they operate very independently of each other, but have kind of at least knowledge that the other exists and had basic levels of communication. So for example, when a patient's blood pressure is high, they could send a note downstairs to our medical clinic or questions about diabetes, but we didn't really have formal processes that existed. So as I present that, just kind of keep this in mind. Okay, next slide, please. And I think most people on this call know this, but kind of reasons that pediatric oral health is important. And I think one of the big challenges we see in federally qualified health centers and community health centers is really just the understanding of why oral health is important for children, especially in terms of parental education. We serve a very large diversity of patients who have various educational levels in terms of health literacy. For the clinic that I serve, most of our patients are immigrants from other countries, and I think how robust dental services are in those other places are very variable. And then kind of normal things that everyone struggles with in terms of limited appointment availability, and then when you get appointments, frequent no-shows. So next slide, please. So in our pediatric integration pieces, what we have done is focus on the topics that you see here. So screening, parental education, fluoride administration, and then our referrals process. And so in terms of our screening, we use EPIC as our EHR and have embedded predefined questions about oral health, frequency of brushing, frequency of flossing in all of our note templates, which really helps pediatricians, family doctors, nurse practitioners who are seeing these kiddos and families not have to remember every sort of thing to hit. And really, I think when you're talking to different families who have different, healthcare needs, dental health and oral health can be one of the things that's not touched on. And so just make sure that you can't sign your note really without at least addressing that question or deleting the question, which you have to kind of acknowledge that you didn't ask that when you do that. And then we have a big component around parental education. Bright Futures, which is the American Association of Pediatric Guidelines, releases anticipatory guidance for every age group, and dental health and oral health is always a part of those handouts and the things that we discuss in terms of anticipatory guidance. And so that is built in, and we have after visit summaries and handouts that we give all of our patients when they leave about what things to expect and how to treat them, just reminding people about brushing, reminding people about flossing, emphasizing that it's 2 times a day and not 1 time a day, which I think is really common with children. And then in our clinic specifically, the 2 big things that we have done and established protocols around are fluoride administration and a referrals pathway. And so for any child who comes in who doesn't have a dentist, they get asked about whether they've seen a dentist in the last 6 months, and if not, we give them fluoride within the clinic. And we've done a number of in-service trainings for our medical assistants to be able to provide that service. We bill for it, even though I don't think we get reimbursed. And then we've also created a handout for take-home information for the parents about what actually happened, because I think in the moment we find that a lot of families say yes to things that they don't actually understand why they're getting and then forget why. And so this little handout sheet says, you know, not to brush it off, not to wash it off your teeth and to avoid eating for a little bit, and then explains why fluoride is important to improve the strength of your teeth for overall oral health care. And then the second piece is that we have a more defined referral work queue, especially for high-risk patients. And so our dental and medical teams are on 2 different electronic medical records, which has made it very challenging to communicate, but we have a workflow in which dental has access into our medical EMR to see all of the referrals, and then the medical team is able to enter them for high-risk pediatric patients. And so this is what we've done to try and improve our pediatric integration. And then next slide. And then about 2 years ago, we entered this grant to really focus on prenatal oral health. And I think this is a topic that isn't really discussed as much in the medical setting, definitely. And so we know that oral health can be linked to poor perinatal outcomes. So preterm deliveries, it can be associated with preeclampsia, gestational diabetes, just from the overall inflammation and inflammatory response in the mouth. And then we know that oral health of the childbearing person is really linked to the oral health of children. And so transmitting bacterial flora from, you know, licking off a pacifier, giving kisses, really before even children have tooth eruption. And that is definitely not something that I think is really taught about or known, taught about in medical school for, or, you know, any health practitioner school for the provider to be able to pass on to patients. It's pretty limited. And then secondarily, it's not something that I think we think about as patients. You want to, you know, be the best parent that you can be and, you know, love on your child. And we're not often thinking about how that affects potentially the oral health of the child. And so I think this is a really new area for our providers and for our medical team to embark on, to collaborate with our dental team around this. And so just, again, challenges in terms of oral health care in pregnancy, other than the knowledge gap that we talked about, but just the frequency of pregnancy appointments. We see people oftentimes every 2 weeks at points in their pregnancy, and then towards the end of pregnancy every 1 week. So to add on more appointments to go to a dentist is pretty challenging for patients, especially if they have other children that they're kind of working around jobs to schedule. And I think all Medi-Cal dental clinics, as you all know, are very at capacity. And so there's always limited appointment availability. And then in our patient population, we had a really large amount of no-shows to those appointments, which then, of course, limits the opportunity for other people to get in. And so next slide. So the biggest thing that we started with was screening, and again, creating an embedded note template in our smart phrases in Epic. And we have a model where we have a prenatal orientation visit that's not done with a clinician, it's done with one of our health educators. And that's where we found that it was going to be the best place to implement that screening, because it wouldn't take time away from a provider visit. There's a lot of other things to discuss. And at this orientation visit, the patient's already informed that it's going to be about a 45-minute visit with a lot of different information about topics. And so it seemed to fit in well there. And most people get this orientation somewhere around 6 to 10 weeks of their pregnancy, depending on when they enter care. And so it was early enough, excuse me, it was early enough in their pregnancy process that we could get them in, you know, at an earlier, kind of like in the second trimester, earlier gestational age. The next slide shows kind of the screening questionnaire that we used, that we vetted with both our dental and medical teams there's a lot of questions that you can ask about someone's dental health or oral health before making referrals. And our goal was to find something that wasn't too lengthy, but was also able to triage patients into urgent and non-urgent appointments. And so there might be other questions that you might be compelled to ask based on your capacity as a clinic, both on the medical side and on the dental side. But these are the questions that we kind of decided on, but basically making sure that somebody, whether they have a dentist or not, whether they've had a routine cleaning, and then really thinking about the question for thinking about what symptoms people might have that they needed a sooner dental appointment versus something that's a little bit farther out. And when we talk about referrals, I think our urgent appointments were getting someone in within the same week, depending on what day of the week it was. And then our more routine visits sometimes took about 3 months to get scheduled. So that's a huge difference for people who are just getting routine screening. Next slide. And so we talked about the screening. The referral process is very similar. And so our dental clinic used that screening assessment via the EHR to identify routine and urgent visits. And then in terms of our parental education, we tried to incorporate multiple different points of education, just given the fact that, you know, pregnancy is a time where people are getting tons and tons of information, and it can be really overwhelming. Repetition is the key to adult learning. And so really thinking about what time points we could incorporate this teaching into. And so we talked about anticipatory guidance during prenatal orientation, about how the pregnant person's oral health might change and how their teeth might change, especially with reflux or vomiting from nausea of pregnancy. At the first prenatal visit, we had the provider do an exam, which we'll talk about a little bit, and then that linked to, excuse me, including more education that's coming from the provider rather than one of our community health workers. At Fluoride administration, which was mostly done by the medical assistant, and then during the postpartum visit, which was really talking about like the link between pregnant person and child transmission. And then of course, at the dental visit, we had the dental team did integration. So they were getting, or education. And so they were getting kind of the same education in a lot of different capacity. And even if they just like took home one sentence, that was a success. And so next slide. One of the big things that we did was a lot of training around what is an appropriate oral health exam. And so our dental team came into our obstetric staff meeting twice and did kind of a, lowdown on what does an oral exam look like, how quickly could you do it, what are you looking for, and then did a 3-month refresher. When we launched some of this project, we felt that, or our providers were telling us the biggest discomfort that they had was actually understanding how to do a proper oral health exam and what they're looking for. I think with children, it's a little bit easier. They felt more comfortable. It might not be easier, but they felt more comfortable doing those exams. And so it was a little bit about just training. And then the medical provider completed that at the prenatal intake visit, and we used, templates that are for all of these visits, and we incorporated the oral exam template in there so that it kind of talked about what different things people were looking for as a reminder, and to kind of prompt people not to forget that in their oral exam. And then we also incorporated fluoride administration as kind of one of our interventions for oral health of the adult. And I think in the setting that we serve, there were a lot of poor oral health. There was a lot of poor oral health, and so there's clear benefit for doing it. But even though fluoride crosses the placenta, it does not seem like there's any benefit for the child or the fetus in terms of tooth development. We did some training of our medical assistants to feel comfortable with the fluoride application. And that was really helpful because a lot of our obstetric medical assistants also do pediatrics. So it was reinforcing what they were already doing. And we applied this as a 15-week visit where there's not tons of stuff going on. And then similarly created a handout for just take-home education so that they could know what happened. So I think next slide, which might be the last slide, just in terms of our experience, I think there was a really strong pull for more collaboration in medical and dental, and having one population that we were both really invested in helped collaboration even in other areas, just because we had staff moving between the different departments, which was really helpful, and just getting to know people as people. And I think that always creates better collaboration when you know people's names and you know their faces. We came up with a really great referral process through the electronic medical record that could be shared by medical and dental. However, there are kind of hiccups in that. And so one of the challenges being that we don't have a bidirectional response. Our dental team provided several in-services, which was probably the best thing that kind of came out of this project in terms of learning. And I think that improved the collaboration and the seeing of faces that I mentioned before. And so some of our challenges were really thinking about the bidirectional communication. So we as a medical team couldn't see if the patient showed up, or if, they no-showed, if they called, what happened at the appointment, to see what the dental team was saying. And so we created some workarounds for knowing whether, in terms of closing the referral, to see whether a patient showed up or not. And then because we're on different EHRs, there wasn't really a mechanism for dental to respond really quickly, or medical to respond really quickly to dental, vice versa, because we're on different EHRs and they have different chat features. So you'd have to call upstairs, which sometimes is just harder, and people are on the phone with patients. One of the biggest challenges that we faced was actually medical assistants not wanting to do fluoride. I think they just don't want to touch the mouth, and had a lot of pushback because they felt like it was more work. Once we really explained to them how it was important in the pregnant person's pregnancy, and how it would help improve fetal care, they had a lot more interest in doing it. But when it was just added on as another task to do as a checkbox, it was really challenging, and it took us about 3 to 4 months to actually figure out what was behind the reluctance to apply fluoride and to overcome that. And then from the medical provider side, as I mentioned before, I think just completion of the oral exam and documentation, A, not knowing what they're looking for, but also B, I think in COVID, with everyone having masks, we all just kind of got out of the habit to look in people's mouths. That's a little summary. And last slide is just thanking people with some resources. And so look forward to questions.
Thank you. Thank you so much. Wow, that was very helpful. We encourage you to put questions in the Q&A, and then I would like to introduce Savannah Wilson. She's the project director for Modoc County's local oral health program, and she'll share her experience integrating medical and dental. Thank you, Savannah.
Hi, thanks for having me. I'm trying to share my screen, but it says that I'm a participant and it's not letting me.
Okay. Cindy, are you able to adjust Savannah? Yes.
Go ahead, Savannah.
Oh, perfect. Thank you so much. Okay. So let's see. Hi, I'm Savannah Wilson. I live in Modoc County. I'm an RDHAP, but I also work as the project director. And today I'm just going to share with you all how Modoc County has helped our medical settings implement fluoride varnish. So thank you to Dr. Walton Haynes and Dr. Cotino on their information. I hope this is helpful for local LOHPs. So today, I am just going to be talking about some of our successes and just some tips on planning for a successful fluoride varnish training in medical offices. I'm going to try to keep us on time, so pardon me if I rush through some of these slides. A little bit about Modoc County. We are very rural. We're in the northeastern corner, and even though we're almost 4,000 square miles large, we have less than 9,000 residents. So we are very rural and very spread out. We have a very limited access to care with only 2 hospitals, 5 medical clinics, and we have no specialty care. So we don't have any pediatric offices, and we don't have any prenatal care past the first trimester, unfortunately. So we do the best that we can with working with our medical providers during well-child visits. And we only have 2 dental offices that accept Medi-Cal. So why fluoride varnish? I think that the prior presentations did a really great job going over why fluoride varnish is so important. Children do see medical providers on average 9 times before they will see a dentist, and it is a benefit of Medi-Cal for children under the age of 6 years old. So the medical settings in California will get reimbursed for that fluoride varnish. And us as an LOHP, actually, we started this under CHDP, and as that started sunsetting, the LOHP program has stepped in and has taken over this portion of the work plan. So as we all know, fluoride varnish is very low cost and effective at preventing early childhood caries, and it only takes a couple minutes to apply. So like Dr. Walton Haynes was saying, integration is very important between medical and dental settings, and overall oral health and systemic health are related. So the training that we did with medical providers in Modoc was through CHDP's fluoride varnish training that was developed back in 2019. And I will show you guys this a little bit, but it includes everything you would need to go into a medical setting and train the medical providers, medical assistants, and doctors on how to apply fluoride varnish. And this is what we did. We scheduled meetings with our medical clinics here. We have a couple rural health clinics, and the local hospital has a clinic. And we did a lunch and learn with the providers where we presented a slideshow on providing medical fluoride varnish. And I'd like to show you guys that. This is the actual fluoride varnish training that we did through CHDP. And what I love about this training is that it really shows, it's really geared towards training medical providers. So it goes over the importance of fluoride varnish. It goes over, why we do it. And like Dr. Cotino was saying, I think that just educating them on why it's important really helped with the buy-in of it. So this training does go over, things for them to look out for in when they're doing just a quick oral check. It also goes over during the training, we do a little practicum with the medical assistants or the doctors who are in there. So we provided all of these supplies so they could practice on each other, which I think really helped the medical assistants get over that resistance to touching people's mouths and to open it up. And they practiced on each other. And by the end, I think everybody felt really comfortable applying fluoride varnish. And I think they were all shocked at how easy it was. So like I said, this is all included in that CHDP training. It also goes over with the medical clinics on how to bill for the fluoride varnish. And it also has, if you go to the CHDP site, it has a lot of resources, including like standing orders. So they can implement it with a standing order from a doctor. This allows the medical assistants. So like I said, this is what we used as our basis for training. Our biggest concerns that came up while we did the training were medical assistants and doctors were concerned about the workflow. So just really listening to them and trying to figure out how to work that in. One clinic was hesitant to try it on all kids. So they came up with the plan that they would do it at specific well-child visits, like the 2-year-old visit and then the 4-year-old visit. And before we knew it, they were doing it at all the well-child visits when they realized how easy it was. So I think just educating, addressing some of their issues. We did not do this, but a lot of counties can offer CEUs. And if you can do that, this would be a great way to get medical providers to want to attend the training. We did just a quick lunch and learn, but you can, if your county is able to, offer CEs for this training. I'm sorry, I didn't realize that was showing up there. So when you go to schedule the training, we just called and asked who would be the best person to talk to. It was usually the clinic managers, and they just set up a mandatory staff meeting that was around lunchtime, and we did it in different shifts. So like we had people sign up for like the first half-hour training, and then another group did the second half-hour training. And this was the initial time that we did it. And since we just go in once a year for new medical assistants or doctors to do the training with them, it was really easy. We just brought in a projector, the laptop, the presentation. We held it in a conference room. We went over that PowerPoint, and then we did the practicum with them. So I really flew through that. But if anyone has any questions, just let me know. Like I said, most of my information today came from CHDP, their fluoride varnish training. And yeah, I think it's just really important and great that everyone is focused on early prevention.
Wonderful. Thank you, Savannah. We do have some questions coming in, so we'll take about 5 minutes or so for questions, and then we'll have around a 10-minute break. So I wanted to first look at the questions in the Q&A. So I'll read them and then you can chime in. So we have, there's a workaround for referral follow-up since the referral management system was not bidirectional. Can you share what those workarounds were and share more about how you got medical staff on board to refer and how you went about integrating oral health referral options into the referral management system?
Yeah, I can talk about some of that. In terms of the workaround, because it wasn't bidirectional, the dental team would kind of keep a list of the individuals that they had that we had referred, and then based on there's a bunch of different options in Epic, and I put them on my slides as kind of extra, so when they get posted, you'll be able to see them. But there's one that, the referral has been sent, and there's pending, and there's closed. And so depending on all of the different options, which I can't remember off the top of my head, they would enter. And so and then they could create comments. And so it was clear to us whether the patient had a pending appointment versus whether somebody had made their appointment and then that was closed out. And on the medical side in Epic, you're able to see as a provider, like all of the different, all of the different comments for what has been happening in the referral. I think if you go to the next slide, Lindsay, it will have, maybe not, maybe I took that slide out, but I will make sure that it's in there somewhere. These are all the handouts that we made in our dot phrases and things like that. In terms of the medical staff on board to refer, I think we make lots of referrals, and so it's actually easier to just enter a referral and know that it kind of like goes into the abyss and that somebody else handles it, rather than every time finding a handout and giving it to them. Our medical assistants did have handouts for not our organization, Medi-Cal dentists, that they could also give if coming to our clinic was inconvenient. But I think getting our medical staff on board to refer was not at all difficult. And in Epic, they have a referral to dental, which is what we use. There's like a placeholder there, and so there's a bunch of different options that say pediatric, routine, prenatal, diabetes. And so you could mention what the referral was for. And then I think more of the work actually was on our dental side, because they got somebody to have access to Epic, and they would run a work queue report so that they could see all of the dental referrals that were placed to that site, and then run through them and call the patients. And so the medical side was pretty easy for that.
Great. Thank you. That's helpful. And let's see. So it sounds like you'll have, there's an additional slide that you can add and share following the meeting.
Yes. Yeah.
Perfect. And then we have a few more, we have some great questions coming in. So there was a question about the link to the training being provided. And so I saw that Dr. Walton Haynes put that in the chat. And so we can also drop that into the Q&A part, the specific link. And then here's a question. My nursing director says because RNs aren't on the AB 667 specifically, they can't apply. What do you suggest?
Are you talking about they can't apply like fluoride varnish or?
Hi, yes, can you hear me?
Yes.
Yes. So I do train people with that same exact training, and my director says that it's not in their scope of work and they can't do it.
Oh, okay. So usually what we do is we have that standing order from the doctor, and they're the ones that can state who can do it. So ours lets nurses and medical assistants apply the fluoride varnish
I have that too.
through
And
that
she said
standing
no.
order
She
because
said
it's
no.
not in their scope.
Yeah, so they went into the nursing. I have that as well, and I have that on there. I have the protocol, I have the procedures, I have the standing orders. It's all on there. But she says if you go to their nursing, it's not on there. If you go to the nursing, what they can do and what they cannot do, it's not on there. And
Okay. Yeah, and I think that there's some, I mean, even people in public health settings with a training can apply it. So I think it's, one of those things where they would just have to use their own discretion. I get that if it's not written in their scope of practice, it's a little tricky, but it's not really a duty that requires, that legislation. I don't know.
Yeah, so we called
Sorry.
the California Department of Public Health, and we specifically asked the nursing, and they just hemmed it on, and we never got it. And she says she needs it in writing.
Oh, okay.
I don't know what to do.
Interesting. I wish I had an answer for that. We kind of bypassed that through the standing order. So does anyone else have any thoughts that are familiar with this training or any doctors that are doing it in their clinics, how they're getting by that?
There's a comment in the chat about San Joaquin County. So I moved that over to the.
Yeah, I did that too, and they still said no.
Okay.
Anyway, thank you.
Okay,
Yeah,
no
thank
problem.
you.
And there was another question. What is the plan moving forward that now CHDP is sunsetting this month? So the LOHAP worked really closely with CHDP's dental parts. So we just kind of looped that over, and we are actually doing that under objective 3.2 in the work plan, which is, implementing prevention and healthcare policies with healthcare providers. So we're still able to do it under LOHP. That's our plan, is just taking over once a year. We do go in and update the trainings. We also update them with referral information every year and are just kind of there as a support as the questions come up.
Great. Thank you for answering that. Can medical providers bill Medi-Cal for fluoride varnish application in an FQHC?
Yes, they can.
So you get reimbursed for pediatric patients, and we tried to see if we got reimbursed for our prenatal patients, and we just never could figure it out in the billing. But we did bill for it just in case. And I think for FQHCs, when they provide more services and you go to, renegotiate your rates, the more kind of coding that you have, the more you can prove that you're doing, and then that can increase your rate per visit, even if you don't get directly billed or just directly reimbursed for it.
Great. Okay. Uh, and then let's see, we have a couple more. Let's see. During the screening questions for prenatal patients, what is the estimated percentage of those that do not want to be referred to a dental clinic, and have they expressed their reluctancy?
I think we had a pretty low percentage of people actively saying that they do not want to be referred to a dental clinic. Say lots of people, you never know if they make their appointment or if when they say that they have another dentist that that they actually go see that person. I think once, if people said no, we said, well, can we provide you some information about oral health care and why it's important? And I think after that, a lot of people felt much more comfortable. The more of the reluctance, if anything, was about fluoride application. And I think somebody else put it in the chat, just, you know, feeling uncomfortable with something that you don't know about. Is this safe? Is it going to hurt my baby? Not really understanding the benefits. And so I think that was the importance of having multiple educations. Not only do you hear it from the, you know, community health worker, but then you hear it from the doctor, and then you hear it from the doctor again. And so kind of this phased piece, and then really providing take-home information too, if that is possible in your setting, so that if people want to read more, ask their friends, etc. And then I think the other piece I would just add is during this process, one of our medical assistants, my medical assistant actually came and showed me a TikTok video about how fluoride is bad and asked me if it was true. And so I think educating our staff was also really important, because they are members of our community and they are going to go tell, you know, their friends and family what is safe and what is not. And so making sure they are really engaged and on board was really important.
That's helpful. Thank you. And then Avery, you had a question about the educational handouts. Was that referring to the medical fluoride varnish training, or another set of educational handouts?
They were the ones that Anna had shown briefly right after her presentation.
Okay, let me just go through.
Those, yes.
Okay.
Mhm. Thank you.
Great. Okay. Well, we're going to, let's see. We're going to take a 5-minute break right now, and we'll continue answering questions in the chat, sorry, in the Q&A section. So before we move to the second half of our presentations for today, we really want to thank Dr. Walton Haynes, Dr. Coutinho, Savannah for sharing their excellent resources for doing this work. Thank you all for your engagement, and we'll continue the conversation in about 5 minutes. There will be a countdown timer that goes up, so you'll know when to come back up for the second half of our meeting. Thank you. right. Hi, welcome back. Hope you had a few minutes to catch a breath. We're excited for the second half of our project directors meeting, and especially because we get to hear some different models from different places. So we're pleased to introduce Dr. David Tappel. He is the Oral Health Program Director for New York City Department of Health and Mental Hygiene. And Dr. Tappel, are you ready to present? Great, welcome. And he'll be sharing on his school program in New York City. Go ahead.
Am I ready to share? Do I have the ability to share?
You do.
Okay, then one moment. How's that?
Looks good. Thanks.
Okay, I'm on a laptop that the microphone has not been working great lately. So if I fade or anything, please let me know. I have to reposition my face to be perfectly in the middle. But thanks for having me, everyone. I'm always appreciative to speak to my colleagues in California. We have a long-time relationship with Dr. Kumar. I hope that we can continue this relationship, that he's not there anymore with your office and all the offices throughout the state. I know there's some people that know me on this call and many that don't, and I'm happy to talk to anyone, anytime. I love collaborating as much as possible. But we're very specific about what we're talking today, and that's school-based dental care in New York City, which is why I was invited on here, because Dr. Kumar knows that we've done a lot of work and progress since his time in New York and since he left New York. So I'm just going to get into it a little bit here. So I was told to have objectives. So we want to understand the ways that the New York City Department of Health and Mental Hygiene, which is the full title of the agency here in New York City, has advanced school-based dental care in the city, and to help you learn from best practices and experiences to continue growth and maintain sustainability of school-based programming. This is a short amount of time, and New York City is a big city. So I'm going to try to touch on different things briefly. There may be things that are more interesting and relevant, and we can talk later after questions some other time. But please, if there's something that hits you, please let me know in some forum or another. So just quickly here, there's, I think I'll show you in a second, there's about 1,800 public schools in New York City. Around 1,000 of them have assigned school-based dental providers. Doesn't mean they're all necessarily be seen, which we'll talk about, but most of them will be. And of the children examined over the last quite several years, we see pretty consistently 40% have untreated cavities. A lot of surveillance that's done through the city, through the agency, oral health questions that's done various surveys that goes out through the city. So this is not specific to schools, but this is one we found relevant as we've followed this one over time. The differences in prevalence of preventive care among different ethnicities. So as we see, it's not necessarily that there's big disparities in going to the dentist actually in the city, but what we do see is kind of like the reasons for going to the dentist. So fluoride sealants are much more likely to receive in a white population going to the dentist. We presume that population is more likely to go for routine visits, be offered those types of treatments, as opposed to some of the other populations listed here, which may be going for emergency care and we're only getting restorative care and not being offered the preventive treatments for whatever reason. So that's kind of the background here. And we know that there's a huge group of people that are not getting preventive treatments that would help prevent the cavities that are at 40%. This is what our program does. We have these 5 key focus areas, which are education, surveillance, quality assurance and improvement, policy, direct services. So the school-based part of things is really the education, the quality assurance, direct services. Policy can be all kinds of oral health policy throughout the city and the state that we work on. Don't have time for that in this talk. A little bit of history going back. There were all these clinics, these fixed permanent clinics, and this is relevant, fixed permanent clinics throughout the city. They sat in schools, they were underutilized, they were underfunded. They sat empty, they were not very versatile. The agency had paid a bunch of dentists to run them for many, many years. These were phased out in 2010, 3 mayors ago. And but we could not phase out the entire concept of school-based dental care because this is irrelevant. This is CDC, evidence-based, school-based sealant. So it was brought back in the oral health program, which existed in the agency, but in a different form, focusing on public health and education, said, hey, how do we bring these services into schools in a much better way? And that's what started to happen around 2012 and then took off in 2014. And which is to where you see now that number, which is close to 1,000 schools. And depending on the date, this is changing all the time. You may see that number slightly different in certain points in this presentation. So we're brought in to expand school-based dental services, strengthening the volume through the existing providers, which I'll show you. There was a handful, bringing in new providers, which is not easy. They have a strict set of city and state requirements, and getting more kids involved. The biggest part of this was the introduction of portable dental care. And that's where we were really able to take off because of bringing in these vendors, help them get what they needed to get, and take off with the portable dental care and away from the fixed clinic model, which still exists, and I'll show you. We wanted to monitor and verify the quality of services, right? So we have to know who these people are running around the city. We have to be able to tell the education department that they're doing a good and important thing. And ensure children needing additional care receive it. We have to close the loop, or we're missing a key part of this. On the left side, we did do a vital signs last spring for New York City focused on oral health. And that's some of the data that was published. As you saw, the increase in decay as the child advances through childhood from the 2 to 13 group in the middle school and the high school group, you see those increases. So this is what happened since we were involved in the program. And I can say I was involved since 2014. I've been the director for over 3 years. I was not the director then, but I was in the program in other roles. You see the large increase in care from the 105 to, I guess this is the beginning of the school year, September at 917. You see a few dots to a lot of dots. That's the point here. But this is strategic. We have mapping that we do to figure out where and how to send the resources. This particular map is looking at HPSA, right, dental health professional shortage areas on the right, looking at poverty areas on the left. Again, the dots are too small for you to see probably where you are because there's blue ones that are with dental and black ones without dental. It's hard to distinguish, but they end up kind of naturally. We help direct the traffic, but they kind of end up gravitating naturally to where they need to be because those are the schools that are going to be desiring it the most, seeking it out. New York City also put up during COVID something called a TREE, which is a task force on racial and equity racial inclusion and equity. So basically, these neighborhoods were the ones most hit by COVID-19 and affected by that. And again, where do the dots end up? They end up right in those spots as well. But there are still lots of schools you can't appreciate from this that are in there, those regions that are unserved, and that's where we continue to make sure the resources go. So this is kind of an overview of where we are with school-based dental right now. So like I said, there's 1870 schools within the DOE, including 274 charters. So about 1 million students. We currently contract with 15 external providers. They have, again, I'm not going to get into it, but they have a lot of things they have to do to be able to, through the city and through the state, to be able to do this work. There's only a handful that would even possibly qualify to be able to do it. Through that, there's 852 schools that are assigned as portable clinics, 110 as fixed clinics, many of them as part of a school-based health center, though not a bigger school-based health center with full range, though not necessarily. 26 as mobile dental van clinics. Schools love mobile dental vans. They say, where's the van? I want the van, because it's easy for them. They don't have to do anything in their building. The vans are hard to run in the city. They are hard to park. They crash into things. They're always broken. They sound nice. Vans are not fun in the city, though. We discourage it. There's a memorandum of understanding that each of them have. Within that, there's a lot of DOE jargon, but all the providers must place fluoride and sealants unless contraindicated. There's no screening programs allowed in the city. Too many folks were coming in doing screenings for their own measurements, for their own metrics. No one was getting anything out of it, and it didn't make any sense because you went to all this trouble and had this child's mouth in your hand, and you didn't even took the second to put fluoride in it. So that was eliminated several years ago. If you want to come into schools and you want to get involved in oral health, you're going to have to place sealants and you're going to have to place fluoride on the dental side, medical side, obviously not sealants. At this point, most provide SDF and many provide fillings, x-rays, and other comprehensive treatment as well, especially in the school-based health center setting. We have strict set of case management requirements as well for afterwards. There's a bunch of names here. This is actually the first line says school-based health center dentals. So there's actually 6 or 7 within that category, but it just kind of gives you a sense of the spread of how many schools are being served and the differences and the different settings that they can be served within. So they're all doing the preventive, like we talked about. Many of them are doing SDF and some are doing the restorative as well. That's the only point here. This is what a portable clinic might look like in a city school. This is a pretty big room. This is a pretty, they're in all kinds of rooms. We work very, very closely with the school to try to get them in to make sure they're in clean, safe spaces. But this is what an average clinic with a few chairs, 3 chairs in this setting, would look like. There's a check-in area. They check in, they make sure that the child has to identify themselves through 2 points of information, usually name and date of birth. Sometimes the little ones have trouble with date of birth. They can answer anything else in the consent form, parent's name, address, anything they can say. If they can't identify themselves through 2 points, they're not going to be seen. Actually, we cannot go by a teacher saying that's who that is, because teachers are wrong all the time. I saw it just the other day, a teacher brought the wrong person into the room. They have to be able to identify themselves and say who they are from the consent form. We collect a whole bunch of data. This is some of that, looking at how much services are being provided, as well as outcome data, decay, untreated decay, arrested decay was added recently, measure SDF. We want to evaluate the success, reviewing the volume of services, addressing any areas of low rates of services. We're constantly reviewing and seeing if there's any updates that need to be made. We had more indicators than the State Department of Health had in their reporting, and actually this past fall, they adopted all of our indicators. And we're continuously reviewing state and local and nationwide data sets to make sure we're collecting everything so we have all the information. And this is some of that data comparing year over year. This year is only through 3/31 because that's when the third quarter ended. I don't have the quarter data available yet. We expect by the end of this year, around 100,000 children will have examinations, because you see close to 80,000 had it at the end of the third quarter. So you see there was where we stood in 2018-19, and then the big dip during COVID and right after COVID, and the climb back up. Consistently seeing around 40-41% decay, seeing the referring to off-treatment sites of 40% because of treatment that can't be done, and the numbers of sealants. So again, last year about 46,000 got sealants, 77,000 children got fluoride. Those numbers might sound like a lot, or they might sound a little, depending on what district you're in. With 1 million kids, it's actually not a lot. So we have to we're continuing to expand and work on that. And a lot of that's through our partnerships with the Department of Education, which are incredibly strong and unique. In our office is actually half Department of Health and half Department of Education, because there's something called Office of School Health. So we have access to tremendous resources in the DOE that I understand that many cities might not have access to. This is just as well kind of summarizing because then I don't have a lot of time. The quality assurance unit, which was developed then, that was kind of the next level to make sure that everything's going smoothly, make sure that folks are providing care properly. And so we have 2 dental hygienists that go into schools unannounced and observe clinics. We have an electronic template that's developed by IT here that they complete based on the visit. They look, they're not looking really necessarily at nitty gritty like records. They're mostly looking at the care, clinic, how it's being run, sealants, technique is appropriate, education is being provided appropriately. And we make a lot of quality improvements through this work. I talk to the dental directors directly with any concerns or issues among those organizations. They're all very responsive and work with us immediately to take corrective action when they need to. But again, these are unannounced visits. We have the calendar of all the visits going on any given day through shared calendars that they update, the providers update. And you'll see that's what it says at the bottom. Urgent issues are addressed right away, not urgents. We talk through during meetings, corrective action plans, everything you could expect as part of quality assurance. And we have folks that are really experienced at this because we've had the same 2 hygienists doing this for about 6 or 7 years. So they are experts now at everything with school-based dental. Then we have case management. We had to grow this case management really from scratch because there was non-existent. We developed a dental referral form to validate receipt of care. So afterwards, phone calls are going to be made, depending on the urgency of the additional care that's needed. The referral form is a form that the dentist signs and faxes back to the school-based dental provider that indicates care has been initiated. So then they can say, okay, we know that this care has been initiated. They make phone calls as well. They have to make the phone calls, but the phone calls don't necessarily verify the care is initiated. You may get a verbal confirmation, which we may or may not consider valid. We did numerous pilot studies to figure out the best types of system. That's what they mentioned there. Most recently, we developed partnerships with the dental insurance managed care through the Medicaid providers in New York City. There are 3 dental insurance providers on Medicaid, and we partner with 2 of them right now. They do case management. They get lists of children from the provider that the provider couldn't reach, and they work on trying to reach them. They'll set up appointments if they can. So then we get another level, and then we have another level, and that is the nursing. And that's the last point. We have an automatic, it's called the Automated Student Health Record. It's the EMR that all the 1 million kids are in for the health records in New York City schools. Urgent needs get fed into that system and the nurses find out about it. It looks something like this. They get an alert and it says right to them, if that child pop goes into that nurse's room for any reason at all, that they come in with a headache, the nurse is going to open their record and they're going to see that there's this urgent dental need, and they're going to follow up with the parent as well as part of that. Hey, your child's here with a headache, but I see this problem going on, and they're going to enter notes. And then another level of case management, there's a lot of levels, is we have our own case managers making phone calls too, but we can't take on that many. So we hope by the time it reaches us and it's gone through all these levels, the number of kids is as small as possible. We maintain a low-cost dental provider list for New York City that you can find by searching on zip code. This is really important because we're calling all these parents and they're saying to us, I don't have insurance, I don't know where to go, I don't know what to do. So we maintain this list. They can go and look up and find low-cost dental providers, sliding fee scale, all these requirements they have to meet to be on there. We work, there's something called 311. You can call, they will help you get insurance. They will help you get a dental provider. It's 311 does a million things in New York City, but we made sure that they're trained to help folks on dental care. So I don't know how timing, I'm sure the timing is probably getting late, but we're nearing the end. Some of the barriers, consent rates. We developed what's called the consent benchmark program, which is funding that can go to a school directly for increasing their rate by a certain percent. We worked with the school on technical support. We've developed one-pagers and details that tell them what they can do to increase their consent rates, which again, I didn't even get into, but is the biggest barrier. Consent rates can vary from 1% to 80%, 90% in some schools. So it really depends on the school and what they're willing to take on. We developed educational programming by working through health teachers to get information out that way. Cavities that were not getting addressed, and the same child was coming back year over year with the same cavities getting bigger and bigger. We purchased STF, sent that out to all the dental providers to use. We wanted more children to get sealants and fluoride. We put that in the MOU, like I mentioned. We created a negotiated acquisition, which is basically a contract that said year over year, if you provide more sealants and provide more fluoride to more children, you will get money for each year over your previous year's baseline. And so that's funding that goes out, and that motivates the providers to put in the extra work. I talked about school cooperation, reaching more students, because in the school-based health centers, many of them seen on the medical side, not the dental side. So we trained all those medical providers, or as many of them as we can, on placing fluoride. We have, I know this was talked about earlier, we have a training with pre-CME and CNE that we developed for school-based health centers, medical providers, to learn how to place and how to have a workflow and how to refer. So do the screening, do the fluoride, and place it. And so we increased fluoride uptake by using the medical providers as well. And then we talked about another barrier, which is confirming that children that need additional care, receive it. We talked about nurses, the dental insurance, case management system, and the referral form. Financial stability, sustainability. Again, I talked about, and this is something we're doing actually a study right now, trying to get deep financial information. We just lobbied for and successfully got money in state funding for the first time for school-based dental care. But I talked about consent benchmark, which is fund for increasing consent rate. I talked about sealants and fluoride increase in our contract. New York State has a similar grant program as well. We provide a lot of materials directly. We use our own budget to provide a bunch of glass sealants, a bunch of fluoride, and SDF, and ship this out to these organizations to help them as well. Those are some of the ways we help sustain. This is what the module looks like actually on the training for the fluoride varnish that we also developed as a way to help. So they don't have to worry about spending money on their training. And that graph just shows the increase a couple of years ago, the increase of fluoride varnish applications and how we train them on referrals. And we have several ways of referrals. And so we have to help them and show them, because otherwise they don't know what to do, and how to get folks into a dental home and all the resources that we have to do it through our webpage, through 301, through what's called the health maps that I showed before. We put out all these public health messages that I don't have to tell you guys about, the different ways to get fluoride, the tap water of New York City, the importance of sealants, the importance of visits, nutrition, and we have all kinds of fact sheets in all kinds of languages, and we get it out to the schools, we get it out to the health teachers, we get it out to every health event as possible, we get it out to the school-based dental providers, and we have our own health educator as well. We implemented education on HPV. This is, we have a couple fact sheets, one on HPV and one on tobacco, specifically for school-based health center dental settings where there's no parent present, and helping folks be comfortable having that conversation. So we really started to increase the importance of education in that setting as well. This is a sealant brochure for parents that's really, really popular because all this stuff can be ordered for free, and we have like thousands of it gets ordered all the time in New York. And we get it translated to all the languages. This was the city health information for pediatric providers, talking about what the available resources are. These are FAQs that go out with the fluoride, they go out with the SDF. Just having a simple document with NYC logo holds a lot of weight. We translate it. Folks are really excited when they have it all kinds of languages, posters, and everything available on our website as well. So that's kind of, I stopped looking at the time, but how did we do for time?
You did amazing for, I think you had about 10 presentations in one. So
I know, I don't know what to do. Yeah,
hey, we'll take it. That's fantastic to, yeah, just the overlay of how you use data to figure out how to embed your school programs from a health equity perspective, and then all of the great resources that integrate with other topics. It's fantastic. So we really appreciate you running through all of that. We'll point you over to the question and answer. There's a few questions there, and then we'll have a little, I think we should have some time at the end too for additional Q&A. And I also want to turn it over to our next speaker, Dr. Travis Trammell, because he's joining us internationally. So I want to give him his time. He is with Jerry Smiles Mobile Dental Hygiene Practice, and he will be sharing about their school-linked program model with their local oral health programs. So welcome, Dr. Trammell.
Hey, good morning. Good morning, everyone. Yes, it's 2:06 a.m. here in the Philippines. And yeah, it's been a long day for me, so I'm excited to be here to be able to present. They want to go ahead and change over to the slides. I'll try to run through them as fast as possible. But just a little bit about Jerry Smalls. We're located actually in the city of Riverside. So I represent Riverside County and San Bernardino County. Just waiting on them to change the slides over there.
Cindy, are
And
you?
so we've been actually in the school district.
Sorry, I'm just checking. Cindy, are you able to pull up the slides?
Yes, give me a second.
Yeah, so like I said, we're representing San Bernardino County and Riverside County. We've been working with them for the local oral health programs. Actually, my school-based dentistry started in 2015. So I had a lot of groundwork already done prior to the programs actually starting. So our transition was a little bit easier than most of the counties that are going through. I already had contracts with at least 20 school districts. So it made it just that much easier to be able to share data and work with the two local oral health counties doing the projects there. So the first slide talks about so the first yes. The next presentation. It just talks about basically school-based dental health programs are being offered by dental professionals, dentists, dental hygienists, and dental assistants. But in my program, we basically use RDHAPs. I have about 12 RDHAPs, registered dental hygienists and alternative practices. Most of them have their own practice. And basically I contract with most of them to basically get into the school districts. Currently today, we're actually in 24 school districts and working with, actually we just added on, thanks to Claire up in San Mateo, collaborating with her up in their area to try to get their school-based program up and running. It's been awesome. You know, I always say working with the LOHPs, there we go. Working with the LOHPs who have some dental knowledge is great. For those who don't have it, it's even easier because I get to teach you everything that I know and how to actually get your program up and running. Next slide, please. And actually that, there we go. So working with that, first, I think this is actually going through the same consultation that I did with San Mateo County. Is which program will you target? Do you want a kindergarten oral health program or do you want a school-based sealant program? And it's totally up to you because it depends on how we would attract the local school districts, who are going to be your partners, and how we're going to implement the process. There's a lot of background. So I always say we cannot have a shy LOHP because if you're shy, how are you going to meet? How are you going to be able to market? Because Claire will be able to tell you there's a lot of work in the background that you have to deal with. And then finding out your local providers who are willing to go into the school district, because as you know, coming out of a private practice to go into a school district to do some screenings, That's a lot, because if you're looking at, like me, every day payroll, screenings don't pay the bills. And as you can see what some of the counties, and there's a lot of different arrays of how they pay, and looking at the different programs, there's a lot that goes into it. So we always say, okay, director, are you going to talk with the school district nurse? Are you going to talk to the wellness directors? Are you going to talk to the student service directors? These are all at the district levels of how you're going to be able to partner with these different schools. So you have a partnership with the schools, and you also have a partnership with your providers, because your providers are going to be your eyes and ears in the community, and how much of a collaboration are you going to have? So all of your partnership meetings of your different providers that are in the community, different agencies, as you see on here, we're talking about maternal health, we're talking about hospital care, you're talking about your dental care, and integrating all those together. And mental health is also a part of it as well. So integrating all of them into your strategic plan, it takes a lot of collaboration there. And so, like I said, I run both programs. I run the kindergarten OLS assessment program, and we also run the school-based sealant program. And they're both taking different equipment as well. So when we're talking about working with the school districts, there's an MOU in process, a memorandum of understanding. Who controls that memorandum of understanding? I have both. Sometimes the counties have the districts, which makes it a lot easier if you already have those, because you're going to change providers all the time. So I'm going to be speaking a little bit fast. So if the county has the MOU, you can always switch out providers, right? But if the dental provider has the school-based MOU, then if that dental provider leaves, guess what? You got to start the process all over again. And so far, I've been lucky with my school districts. I've had them all over now. Almost, this is my 10th year actually in doing school-based dentistry, and it's been a success. We've had a lot of ups and downs and learning, and there is no two school districts alike. So whatever you do in one school district, you're gonna have to tweak that process a little bit just to get into the next school district. And the insurances and all those things that we're talking about. So when we're setting up those meetings to discuss the potential partnerships, what does that look like? Are you going to send your RDHAP, since they have their business? You go get the school district contracts, the MOUs, and then we'll fund you for your data. That's one. Our school districts, you go get the MOU, you have everything in there that you're all the insurances are set, the MOU is intact, you got all the partnerships ready to go, and now you got your RDHAPs, you go find them. How are you going to do the RDHAPs? Will you be contracting with the RDHAP, or you're going to hire the RDHAP? Because those are totally separate as well. Contracted with the RDHAP, they're on their own schedule. Employing the RDHAP, they're on your time. So now you're going to hire them for 8 hours a day. What does that look like? You know, how is that going to be? How is that going to work for you? Now, because if you got the schedules, because like I'm working with Claire, there's 9 school districts in one city, right? So now if you're the employee, you only have 9 schools. What is the hygienist going to be doing the rest of the time? You know, hopefully we're looking for more school districts, because if you got them for 8 hours a day, you need to make sure that you're fulfilling their roles and their time, and, you know, it's beneficial on both sides, right? And so I like the contracting phase. Why? Because we get to manage our own time. We get to move around. I get to bring in more APs, and then we get to expand. We get to grow. And so those are some of the things that you want to look at, and making sure that both times are being efficient and effective, and making sure that you're getting the goals, you're hitting your goals, you're getting the data that you're wanting in a timely fashion. And so when we're talking about, like I said, when we're talking about employing the contract, employing RDHAPs, and then when we're talking about hiring the RDHAPs, you know, because they get, hey, I would love vacation times, right? But I have to, as a contractor, I have to manage my own vacation, right? When we're employing, now they're part of you, but you get to do a lot more, you know, and you're working with the data sets, and you're working with the flyers and all those things to get the schools motivated and doing your programs. And you're going to have some schools that say, no, we don't want that program. You know, no, we're not ready for that right now. No, that's going to take too much time away from my teachers already, which we're already understaffed. So those are some of the things that you're going to be coming across when you see those. But we see them every day. You know, it's a meet and greet. You're always in their face, you know, because you have a program that we're trying to implement. We need the data. They have the kids, and we just want to make sure the program is effective and it's sustainable. That's the main goal, sustainable. Now, me, with Jerry Smiles is a twofold. It runs as a for-profit, Jerry Smiles Mobile Dental Hygiene Practice, and it also, you go to the next slide, it also runs as a nonprofit, which also now, that's how we get grants. I have a grant writer, being able to get those sustainability funds, because as you know, if you're doing a kindergarten oral assessment and you're paying a per kid assessment, next slide, it's not sustainable. Because I've seen the numbers, I've seen what different counties are paying the RHAPs or the dentists, you know, depending on where you are and what's going on there, is how to create these programs and to make them sustainable. So I can only sustain my program through the sealant-based program and dealing with, like you said, we did prophies, we do sealants, we do the fluoride, and we also do the SDF as well on the kids. Because sometimes these kids will go through the first line of defense and the parents don't have time to take them to a dental office. And so those are some of the things that we look at. Next slide, please.
Oh,
There we go. And so, and it's like I said, sometimes these are the kids are the first time that we're going to see them, and we may be the last one. Like some of the counties, there's not a lot of Medi-Cal providers that are there. So at least when we get to them, we try to take care of as much as possible while we're there. And in some instances, I use teledentistry too, because during COVID, teledentistry came into effect when my Riverside County Office of Education came to me and says, "Hey, Tramel, we lost our dental provider. We need you, and our kids aren't in school, they're at home. How are you going to screen our kids?" And these were all the preschoolers, right? And so I had no idea, because it was the first time I had even experienced this conversation, and because we didn't know what COVID was going to do and how it was going to affect us, that I had to create a model of teledentistry just for the preschool services. And you can do it for your kindergarten oral assessments as well. And so when they asked, "How are you going to do that?" And so we were on a Zoom meeting as well. And I says, "Well, I guess the only way we'll be able to screen them is through Zoom." I said, "How are you going to screen the kids through Zoom? Can you see?" I says, "Well, of course, I'm not in proper lighting in this hotel room here." I said, I said, "Go over to your window and let the sunlight in. All right. Turn, you face the window and put your screen up in front." And so when they were able to do that, and I said, "Now smile at me." She smiled. And then I was saying, "Now open your mouth, lift your head up to the ceiling." And so basically we did an actual screening right there on the screen. And she says, "Wow, that was pretty simple." So for 2.5 years, that's what we actually ended up using teledentistry to help expand the functions to get that healthcare done. Why? Because they had 45 days after the school started to actually get all their kids screened. So using teledentistry in our rural populations is where it's at. Because if you don't have providers, that's what you have to do in order to get them some type of care. And I know they're expanding functions and things like that, looking at different models. But what I try to do is find as many RDHAPs who are out there looking for work. Right now, in each one of your counties right now, there's so many dental professionals that are out there that's actually looking for work. Like I was able to find 4 for San Mateo. They all have to drive a little bit. So we got to find a way with these programs to help make them sustainable and make them worthwhile. Because I know different areas driving is everything. Why? Because we're RDHAPs. We're what we call mobile dental hygienists. And to be mobile, I always say to drive. And I laugh every time I say this, because I bought my car, the second one now, last year, June, Father's Day weekend. And to this date, it's not even Father's Day yet, I've already done 43,000 miles on it. And so just let you know how passionate I am about mobile dentistry and going to where nobody else will go. That's what we like to do. We go and provide the care because everybody needs care. And that's where we take pride, and especially this oral health care and the quality of it is making sure that everybody who has teeth deserves to smile, right? And we want to make sure that's a healthy smile. And we don't just do dentistry, we do I always call it health and wellness. Because with your dentistry, we talk about diabetes, we talk about the high blood pressures, we talk about the obesities, we talk about all those things that affect your overall mental health. And those are things that we like to look at. And when we have urgent cases in the schools, basically our nurses are the first line of defense, or the health clerks. Those are the first line of defense. And if they don't, we still have the data inside all of my regions of my school districts. I have what I call as a short call list. And those are all the dentists I've actually personally talked with and actually have shown a report card to that allows them to know, when you see this report card from Jerry Smiles, this is a kid that is urgent, that has been screened, that has been cleaned, fluoridated, and probably sealant placed. Basically, they're coming to you for services. And usually my urgent cases with the parents, I give them, they get 7 days to make that appointment. And the dental office also gets that information as well. So they got 7 days to make that appointment because, as you know, once it's been shown that there's an urgent care, there's a health need, then we are their mandated reporters as well. And so I do let them know that. I'm not afraid to let them know, hey, and I will report because this kid is actually in pain, an abscess can occur, or some other systemic issue could happen as well. So we just will try to be as vigilant as we can be while we're out in the community and serving them. And the next slide, I think it's the last slide there. Yeah, so questions. But we just love what we do. We're always open for consults. We're always open to go out and share and to just move forward in the process. But as Claire can put in the chat and let you know, it's a lot of work. She is awesome. She's amazing, and keeping us all together and making sure between the county oral health program and the RHAPs and the flow of things with the school district that we collaborate and everything is clear and concise. And, we try to just move the barriers, because as we create a lot of barriers on our own. But we just want to make sure that we create a stable environment so the programs are sustainable and the kids who need to get served, get served. Thank you so much for your time.
Thank you. And great that all the no blackouts, everything stayed on. Thank you so much for coming in and making the time to do this. So we have one question, and then I want to move to our next presenter. So Andrea. And we can't hear you, Andrea, but it looks like you're off mute, so I'm not sure. If is it possible to drop your question in the Q&A? Okay, we'll come back because we can't hear you yet, but I want to move to our next presenter, and then we will have plenty of time for Q&A too. So Sarah Vogel is the Oral Health Project Coordinator with Humboldt County's local oral health program, and we're looking forward to hearing about Sarah's school-linked dental program. Thank you, Sarah.
Let me try again. Thank you for having me today. I'm Sarah Vogel, Oral Health Program Coordinator for Humboldt County Public Health, and I'm here today to discuss our school-linked dental program. But first, I wanted to share a little bit about our county. Each and every county is unique. We are blessed to have 6 Medi-Cal dental clinics. 2 of those are exclusively serving our Native American population. Those clinics have 2 separate dental vans that serve our region and are mostly focused on providing school-based services during the school year, and then community service, basic services to communities over the summer. We do have 40 private dentists, none of them except Medi-Cal, and 40% of them are planning to retire by 2027. So we are really going to be experiencing that gray wave, and it's going to impact our ability to get dental care, whether or not you have Medi-Cal or private insurance. So basically, we're in the position of needing about 84 more dentists for every single person in our county to have a dentist. We have a population about 135,000 folks. But only about 20 of them live in the county seat. 20,000 of them live in the county seat of Eureka. So we are spread out over many, many, many miles. There are some areas of Humboldt where people live and they never venture into the other half of Humboldt. Very isolated. So that creates some challenges. For our schools, we have 31 school districts, 51 primary schools. So some of these school districts are just single schools. A lot of these school districts are just single schools. So it would require a lot of MOUs to have partnerships with each of them. And considering that 44 of our schools have 50% or more of students eligible for free and reduced lunch, that's almost all the schools have that great need. So we really do have to prioritize who we serve because everyone is in need in our county. And historically and currently, about 1 in 4 kindergartners start school with untreated decay. So a little bit about our school-linked program design. We have MOUs with 10 school districts that have the highest percentage of untreated decay. These agreements allow us to do screenings using passive consent. We utilize 3 RDHAPs who are contracted with the county. They are not employees, they're contracted, and they charge a per hour rate to provide screenings at our school. Our role in this design is that LOHP staff coordinates the screening logistics with the schools and documents the screening results and prepares the reports that go to the family. So we do a little take-home screening report that goes home with the family, along with information on where treatment is available based on your insurance type. If the school allows, we do reach out to the guardians of students who have untreated decay to offer care coordination. But I do have to mention, I know this isn't going to be a surprise to any of you working in schools. This is a challenge for us because even though we will have an MOU in place with the school district that says part of this is that we are going to care coordinate for the students that have dental issues or untreated decay, once in a while, you will run into a protective gatekeeper at that school that will just not allow you to contact the parents. And despite what any MOU says. So a little lesson learned this school year is that we need to make sure that ducks are in order and that the school itself understands the agreement its school district has made to have us come in and do screenings, and that the care coordination piece is important because screenings alone isn't enough, as has been mentioned before. So when we are allowed to, we have a care coordination program. It's called Smile Humboldt Family. And it is a program of public health. We utilize a community health outreach worker, and she assists individuals and families with making dental appointments and establishing a dental home, coordinating transportation assistance, and sometimes that's just making a call to our managed care plan to assist that client in making those transportation plans. This also involves reminder calls, which are really, really important, particularly for families who have a lot going on, multiple children. Our clients find it really helpful that our care coordinator will call and remind them, you've got that appointment, let's call together, make sure that ride is really set up with the Medi-Cal provider and that this is going to happen. So it's a lot of really useful hand-holding. And I want to mention too that this is sometimes the only person that will walk and talk them through their dental trauma. Because she wants to get down to why they're apprehensive in getting their children care. And as we know, oftentimes it goes back to their own trauma and their own fears. So this is someone that can walk them through that and assure them, you know what, that dentist you're sending your child to, I know them, they're going to treat them just right. So the other thing we're able to do is we will ship them dental supplies. And as I mentioned, we have some rural areas where there literally is not a little mini store to even get dental supplies. So this is pretty crucial. and we offer oral health tips and education. So when the idea of school-based dental program was introduced, I was really excited because I wanted to get services into the school. And when we started to explore that and utilizing our RDHAPs and how that would work for billing, I connected with the current school-based dental van programs to see how things were working on their end. And through that conversation, we really realized that the vans themselves were not being utilized to the extent that they really could be. And so we made a decision, instead of reinventing the wheel, to try to improve what is already happening in schools and with these dental vans providing services. So kind of partway through this last school year, we jumped into a partnership with Open Door, who's been providing dental van services in schools for over 20 years. And with that, we provided the support that they were missing at the schools. And that is working with the schools to make sure that it's on their calendar, that the dental van's coming, it's on their calendar, that it's being promoted to the parents, and that the parents fully understand all the services offered. As it was mentioned in a previous presentation, when you've got several different organizations coming into the school and some are only offering screening, some are offering services, it gets very confusing. And sometimes parents are like, no, I'm not going to have you digging around in my kid's mouth for no reason, when they don't truly understand that the dental van could provide them all the treatment that is found to be needed from those screenings. So that is the part that we've been playing, is getting the information out there, helping the schools get the information out there. And we're also doing our screenings in advance of the dental van coming there. So we have an MOU with those schools. We do a pre-screening before the dental van comes in, send home that report to the parent with the good news, reminding them of the good news that care is coming directly to their school. So don't fret, your child has untreated decay. It's okay. The dental van will be here next month, but you need to do the paperwork. So we will send that report home. We will send it home with the paperwork in hopes that they will sign it and have their child get treatment right there at the school. And again, if the school allows, we are able to reach out to those families in advance of the dental van coming and saying, hey, you got our report. Did you get them an appointment, or can we get them on the van? So it's a really a great partnership, and I have Open Door here. Redwoods Rural has asked us to join their process in the next school year and do screenings in advance of them being at their schools, because both of these programs are having difficulty getting parents to sign those consents and getting the type of participation that they really should be getting. So here's just a little example of like one of the things that we gave. Let me go back. We gave to one of our schools to post to their website and their Facebook, just making sure those parents know that the dental van's coming to school and that you could get all of these great services. It's not just a screening, it's everything they need. And so our rationale for partnering with the existing school-based dental programs was that, first and foremost, Smile Humboldt has like a brand recognition in our county. It kind of encompasses everything that's dental, all of our partners, all of our education outreach, everything that is dental is under Smile Humboldt. And what's nice about that is it's a recognizable logo that doesn't belong to anyone. When we come in and we're with Smile Humboldt, there's less of a resistance than we're with public health to look at your kids' teeth. It's the Smile Humboldt people coming in to do screenings. It's just, I think for some counties, particularly the rural ones on this call, that have kind of apprehension from their community and working with public health or government, it has been really helpful for us to get the word out about oral health, get the word out about different treatment opportunities in our community through the Smile Humboldt brand. So that's been helping increase the participation with the school dental vans. Our LOHP has established history and relationship with the schools. So for those schools that have been reluctant to invest the time to have their dental van, we are able as public health to kind of go in there and grease the wheels pun intended, to get that van there. We have a lot of administrative time to promote the use of the dental van, to work with those schools. And I think that's a piece that needed just a little bit more of a hand holding with these dental vans is, they get so focused on providing that direct care that some of the things that need to be done ahead of time to make sure that everything's lined up for that care to be given and be successful, that we're able to do that for them. And then the last piece in our rationale for partnering with them is that we'll be able to share their data that with the Office of Oral Health and really demonstrate that these dental vans are providing the preventative services that we all want our children to have, and that will affect the data in terms of how many children are out there with untreated decay. So from these dental vans, we'll be getting the number of sealants and varnish and cleanings and restorations and x-rays and be able to share that in our progress reports. So that is a very short and sweet overview of how we do our oral health school-based services in Humboldt County. And again, thank you for giving me the opportunity to share that information. I'm happy to answer any questions if this is the right time.
Wonderful. Thank you, Sarah. Yes, appreciate the overview. Love the visuals. We are now going to open it up for questions. Any questions that didn't get answered or where people have follow-up for any of the presenters, we can do that. But if you have specific questions for Humboldt, we can take a few now. So the question that just came in, and then I'll turn it to you, Angela, after this question is, what LOHP staff credentials are providing your screenings? How many kids do you see a year?
So it is the RDHAPs that we contract with that provide the screenings. We are really there to assist in documenting and getting those screening results out. So really, like the LOHP staff that we have, I have myself, which is an administrative position. We have a health education specialist, and then that CHOW, the community health outreach worker that I mentioned, that provides the care coordination piece. And we work as a team at the schools along with our DHAPs.
Right. And then there was a question, how many kids do you see a year?
Sure. So for this year, we screened 674. I think we're going to be closer to like 900 next year. We had some staffing, we had some folks out for unexpected reasons. And so I really see that being maybe closer to 1,000 next school year.
Great, thank you. Angela, go ahead.
Hi. So I'm down in Mendocino County, and it sounds like you have a lot of people involved. The RDHAPs do a lot of the work for you, your CHOW, other people assigned just to education. I didn't hear you mention anything about nursing staff or health aides at the schools. Do you have any of those involved? Because I'm finding that they're my link right now, but one or two of them are much more advanced or able to help than the others.
We collaborate with the nurses and the school health aides in our basic coordination, but not necessarily in providing any kind of screening services. But they are there. We call our school champions the COA keepers. And so some of our COA keepers and our advocates there in the schools are the nurses. But so they do help us get in the door. But beyond that, that's the extent of our collaboration.
Great. There's two questions in the Q&A. Are your RDHAPs Medi-Cal providers, and do they do their own billing? Sorry.
So out of the three, two of them are Medi-Cal. They are able to bill Medi-Cal. And when we talked about doing school-based services where they may go into the school and do more than just screenings, which is, that's what they're contracted to do with the Prop 56 grant, is screenings only. If we're going to provide services, they would have to bill Medi-Cal. And we have not gotten to that point yet. Primarily our RDHAP, who is available to us the most, is retired and has some apprehension about spending her retirement time billing for services. So currently we do not. The other issue that came up is if they are able to bill for Medi-Cal, where does that leave the students who are uninsured or privately insured? And we haven't been able to answer those questions as a program, so we've not implemented them providing direct services quite yet.
Thanks for responding. Great. Okay, are there other questions for Sarah? Okay, I also wanted to look back at the Q&A. There were some questions that were answered along the way, and I'm not sure if everyone was able to see that because it moves them over from one side to the next. But we had, there were a few questions for Dr. Tappel that came in, and then a few questions for Dr. Trammell. So, and then Dr. Trammell, did you have some comments on the questions that just came up? I saw you come on for a minute.
Yes. In my practice, basically, my APs don't even look at the actual whether they have Medi-Cal or not. So we service all kids, and that's just a service for everyone. Yes, some of them do have Medi-Cal, some of them don't have Medi-Cal, but I don't let my staff understand the difference between them all. They're gonna all be treated the same way. So we're gonna treat them with or without Medi-Cal. And that's where, like I said, sustainability does come in effect, where we can bill for the prophylaxis and things like that. So those do help. We basically, I tell people we spread Medi-Cal dollars, as you know, as small they are, we spread them 4 times. So the kids who do get treated, who have Medi-Cal, and we also treat the kids who are uninsured as well. And they all get the same thing. 2 breast kids as well, and I know this is a state system, but somehow God blesses us.
Okay, thank you. Any other comments on that topic of Medi-Cal billing and how to treat all kids? Okay. We had some other questions come in, and this is for the New York City presentation. There were some questions around who developed the materials, and let's see. There were 2 more, but they're not. I lost them in the Q&A. Who develops materials, how services are funded, and then how the MOU is set up with schools. And so I dropped the answers in the Q&A, but Dr. Tappel, did you want to comment on any of those live?
Yeah, I didn't have time to get into billing and reimbursement, but yeah, this all goes through Medicaid, and that's what the majority of the funding is through. Folks also get grants, and we talked about how we support through a couple of grants for the city and through the state, and through providing some materials and other support that we provide. But the majority is through reimbursement. They must treat all children regardless of insurance status, and something like 20% will be uninsured. We try really hard to get them insured because they're all eligible for insurance, but that there is that ineligible group, and that's why you know, they get the extra support where possible.
Thank you. Are there other specific questions for Dr. Tappel or Dr. Trammell? And then also, if there's anything for our first half that didn't get answered, you can also put that in the Q&A too, and we can follow up. Thank you all. I know that we've heard so many great presentations this morning. Again, this is, you know, sometimes we're able to gather in person for our project directors meetings. So we were able to put everything into a 2.5-hour window for our time today. And so I wanted to invite, if there's maybe 1 or 2 LOHP leads that would be interested in sharing a takeaway that they've had from this morning's session. It would just be great to hear how this has been helpful for your work. So if you're feeling called to share what you're taking away from today's time, you can put the raise hand feature up, and chime in. So while we're giving people a moment to think, I just wanted to, we have a couple final announcements that we'd like to share. And so I wanted to move to that. And then so Cindy, there's a slide with at the end with an announcement, if you can pull that up. And in the meantime, we hope this has been a really helpful overview of oral health models for success, medical dental integration, fluoride varnish, pregnancy, and school-linked dental programs. That might be our longest title yet. So did anyone, before we dive into the announcement, did anyone want to share a takeaway that they have from today's meeting that will help in their school-based work or their medical dental integration work? Or is everyone swimming in ideas? Okay. Well, if you think of it, you can raise your hand and I do want to thank our planning team. We have 3 wonderful LOHP leads, Jamie Humph with Nevada, Tiara Munoz with Madera, and Sandra Velasco with Riverside, who helped put today's meeting together. We also want to thank all of our speakers for their time and the great content, and also thank the Office of Oral Health staff who's been busy planning. And there's been a number of leadership transitions, we know, with the office, and it's been great to see the work moving forward and the dedication that this group has. And so we just want to give a big thank you to everyone. I do want to share that there will be an evaluation, and we'll post the link in the chat. And then you also receive it via email. So before we close out, I wanted to turn it over to Dr. Karen Raju, who has an announcement about the Rethink Your Drink work.
Thank you, Lindsay. And hello, everyone. This is Karen Raju from Office of Oral Health. We do have an exciting announcement for you. So the Nutrition and Physical Activity branch from CDPH is launching a statewide social marketing campaign called Not So Sweet Side in July. So it's coming up, and it aims to educate SNAP-Ed audiences about the health risk associated with sugar-sweetened beverages. And although the development phase is still going on, but the department is planning to run some ads on billboards, social media, radio, and TV in markets across the state. So here on the slide, you can see the first baby step that you can register to get the training from the Cal Fresh Healthy Living social marketing campaign. But the timeline for other activities would be one webinar would be following up after this June 13th training session in July, and then the Rethink Your Drink activation would be in September. So they are including so many assets, new assets in the planning and the media toolkit, which would be infographics, some game mats, and some coloring activity sheets, QR codes with nice virtual library of healthy drink recipes. So stay tuned and do register for this training session. I'll put the registration link in the chat for your ease. And with that, back to Lindsay.
Okay, great. All right. Any final comments or questions before we wrap up? Okay, well, thank you. And thank you, Paula, for the mindfulness when we began our meeting, and that we belong in this space, and it's wonderful to see all of the work taking place. We will start planning for the next project directors meeting later this year. Usually it's in November. So you'll get that notice as soon as we have the date. But we do build the meetings with help from an LOHP work group. So if you are interested in volunteering on the next project directors meeting planning work group, please send your program consultant an email that notes your interest. So we look forward to seeing you at the next one. In the meantime, if you have any questions or comments, please contact the Office of Oral Health team. And a huge thank you to all of our speakers and planning team for today's event and for your engagement and interest in this work. We'll see you at the next one. Thank you.